Good evening. Welcome to our gout webinar tonight entitled Treating Gout from Your First Flare to a Chronic Disease, How to Manage Gout and Prevent Future Flares and Other Health Problems. I'm Dr. Larry Edwards, a professor of medicine at the University of Florida, and I'm going to be chairing this discussion group tonight. We have an excellent panel of 4 other people with great knowledge about the disease. But first, let me go over a little bit about what we're going to be looking at. We're going to do an overview of gout, just what the disease looks and feels like, the prevalence of it. It's the most common inflammatory arthritis, far outpacing common things that you hear about on TV, like rheumatoid arthritis or psoriatic arthritis. We're going to talk about some of the misconceptions and myths and maybe the stigmata of having gout. We're also going to talk about treatments, both of the acute flares as well as the important issue of lowering uric acid for the disease process itself, and then maybe give you some advice at the end about how you can be talking to your doctor about better management of your own gout. But before we get started, let me go around the panel and have them introduce themselves. David, if you'd like to start off.
My name is David Guzman. I am 39 years old, and I'm from Austin, Texas. I'm a psychiatric nurse out of Austin, Texas.
Okay. And a sufferer of gout.
And yes, a sufferer of gout.
Most important for
Most
this
important
discussion, right? Rick, you want to introduce yourself?
Yeah, I'm Rick Johnson. I'm a kidney doctor, but I have a lot of expertise in gout, and I'm happy to be here. I'm a professor at the University of Colorado.
Okay. Joan?
Hi, I'm Joan McTigue. I'm a physician assistant. I've worked in the field of rheumatology for 25, 30 years with a focus on gout. I ran a gout clinic at the VA for a long time, and I spent a lot of time thinking about what the barriers to being successful at treating gout are, particularly in a patient population that's not particularly health literate.
Okay. And Brian?
Yeah, hi, good evening all. I'm Brian Mandell. I'm a rheumatologist, professor and chairman of academic medicine at the Cleveland Clinic. Longstanding interest in crystal diseases of the joints and inflammation, and especially of gout.
Indeed. So a lot of expertise on this panel tonight. Let me start off. We're going to talk a little bit about gout and what it looks like and how to distinguish it from other forms of arthritis. And Joan, I'm going to ask you if you could just briefly go over the signs and what the disease looks like early on and how it might progress over time if undertreated or untreated.
Well, the interesting thing about gout is it first tends to make an appearance in a sort of shocking way. It doesn't have a sort of slow set of symptoms. It just seems to blast out of the night. And typically a patient will develop a rapid onset, very hot, warm, swollen joint, usually in the lower extremities. Sometimes it's so painful they can't bear weight or even keep a blanket over it. In the beginning, those kinds of episodes can be few and far between and not even diagnosed, just endured. But then over time, if patient's uric acid remains elevated, then they will continue to have more gout flares more frequently and more severely. And it can get so bad if it remains untreated that it becomes chronic. And it can also be deforming, meaning your joints become not as functional as they could be because they become large and knobby and difficult to hold things. Now, all through these clinical times, the underlying cause of gout is high uric acid, hyperuricemia as it's called. So that can be going on for years, even decades before the first flare of gout occurs.
Okay. Yeah, and David, how does that compute with you as far as somebody that's had gout for quite a long time?
I would say the first time I ever had an episode was in 2016, and it was came out of nowhere. I made an excuse for it as I wore new shoes, had just recently worn new shoes. And that's what I justified the pain coming from, that my foot wasn't, it was my right toe.
Mhm.
And it didn't really get swollen, but it did get very red at that time. So I didn't know it was gout at the time. But yeah, the first thing that hits you is the pain, severe pain.
Yeah, and most patients find that if they try to use that joint, that they just can't. If it's in the lower extremities, they're not going to be walking into the office to see us. Yeah, thank you. Brian, maybe you can tell us a little bit about how gout's diagnosed and how it's distinguished from other inflammatory arthritises like rheumatoid arthritis or psoriatic arthritis.
Right. So, I mean, there are some characteristics of gout that are, I would say, almost unmistakable, but they can be mimicked by other conditions. But gout typically will respond to the dramatic onset of pain in a specific area, one joint, sometimes a tendon, and lasts for a while. The first couple, exactly as David said, is attributed to something. I stepped off the curb wrong, twisted my knee, my shoes are too tight. And then it happens again and maybe repeatedly. And patients will frequently wind up in the emergency room where gout will be suspected. Blood tests will frequently be done to look at the urate level, the serum uric acid or urate level, and then be told they have gout and treated. That, of course, to us as rheumatologists, is not the best way to diagnose the gout because it's not specific really to look at blood tests. Ideally, according to the textbooks, we should look at really where the inflammation is in the joint, numb up the joint, put a small needle in, take the fluid out, look at it under the microscope, and definitively make a diagnosis. And that's important because you have a diagnosis for life and you have treatment generally for life, either with medications, dietary changes, and medications, but something that's going to be that you really want to know that you have that disease. So that's the best way to make the diagnosis. It can look like other diseases superficially. Occasionally people will actually have their first attack in multiple joints, so it can look like rheumatoid arthritis. But I think the first thing is to really make the thought that this could be gout and then get a firm diagnosis, realizing that the blood tests by themselves are not adequate for that diagnosis.
Yeah, exactly. Rick, primary care physicians see the vast majority of patients with gout, maybe more than 80% of them, but rheumatologists and nephrologists see most of the others. In a premier institution like the University of Colorado, I'm sure you see a lot of this along with the kidney disease and the hypertension that you'd be primarily seeing them for. Do you think physicians in the ivory towers like you were in, or in general, are doing a good job of recognizing this disease and getting them started on a treat to target sort of mode?
Well, it certainly has a characteristic, onset, and the primary care docs are by far and away are the first people to see these when you have an attack of gout. So typically it is the family practitioner or the general internist who sees it. But it is obviously a disease of the joints, and so it's often if it's difficult to manage, it will end up seeing a rheumatologist. And likewise, kidney disease is totally linked with gout because uric acid is excreted largely by the kidney. So if you have kidney disease, you have a much higher chance of having gout because you can't get rid of the uric acid, so it builds up. So like 1 in 4 people with chronic kidney disease have gout. Whereas if you have normal kidney function, it's 1 or 2 per 100 that have gout. So there's a huge difference. So as kidney doctors, I see a lot of people with gout. Now your question, is it treated well, the biggest problem is that a lot of doctors won't, often the first attack is not treated. And sometimes even repeated attacks are not treated except for anti-inflammatories. And there's some doctors that will just treat the attack and not the cause. And so, and then there's the problem of having something that, you get an attack, it goes away in 2 weeks, and then they tell you have to take a drug for life. And so a lot of people aren't very good about taking the drug for a long time that lower the uric acid or following the diet to lower the uric acid. And so it's not so easy to have, the majority of people with gout are do not have the uric acid controlled. Maybe 1/3 aren't getting treatment, 1/3 are getting treatment, but it's not adequate, and 1/3 are getting fully treated. So there's a lot of work for us as doctors and as patients to educate everyone to say, hey, this is a disease that's going to keep coming back and back, and we have to get the uric acid level under control.
Yeah, I think this all builds up to the various misconceptions that are held by patients, the general public, as well as probably the majority of physicians. We do need to do a better job of educating. Just going ahead, just looking at these barriers to good treatment. Every now and then the Gout Education Society does surveys of patients that are logging into our website. And one of the recent surveys that we had showed that fewer than 1 in 3 patients getting treatment understood that 1 in 3 patients were actually getting therapies that were going to limit the progression to a more chronic and advanced type of arthritis with destruction. Also said that more than half of the patients that were surveyed said that they were actually embarrassed by having the disease, and that led to them seeing their doctor less often, of discussing it with family members, and so forth. And finally, 9 out of 10 patients with gout get their information about gout from some source other than their healthcare provider, usually from the internet, from friends, from stories from their own father that have the disease. And I think all of this leads to some of the misunderstanding about it. Does that ring true to you, David? Again, as somebody that's had gout, where did you turn first for your information about gout?
The internet. When I first was working at a clinic, I described my feelings what I was feeling to a coworker, and he told me the word gout. I had never heard of it before. And he told me a horrible story about someone he knew with gout, and then I didn't believe it, so I went to the internet, and that's where I got a majority of the initial knowledge of what gout is.
Yeah, to a lot of people, gout is just that episode of flare that are terrible in and of themselves, but there's very little talk on the internet about what a progression ultimately will be if you don't treat it correctly, to having destructive arthritis, every bit as destructive as rheumatoid arthritis. And I think it shouldn't be used as a scare tactic as much as an incentive to get the disease under control. Are there any other observations about the disease itself from panel members that we should talk about?
It can, in patients with kidney disease, it can present a little more atypically. It can sometimes affect more than one joint at the same time. And we're also recognizing that gout can, that uric acid crystals can sometimes deposit in the back, and back pain can sometimes be due to uric acid crystals in people with gout.
Yeah.
So we're learning that it's, it has a wider presentation.
Yeah. There's a term that physicians use called allodynia. It's not one that most people in the lay population know about, but it's the concept that you can elicit pain by just the gentlest of touches, something that would not be perceived as painful to most people in the world. But in patients with gout, if they have an inflamed joint, just again, the lightest touch, a sheet rubbing over a joint is excruciatingly painful. I think that's one of the hallmarks of this disease. I can't think of another form of arthritis that has that as its underpinnings.
Yeah,
Joan?
Something you can push through.
Yeah, that's right. Joan, you did run a gout clinic for a couple of decades, and you were confronted with these myths and misconceptions all along. How do you overcome these things, even things out on the internet that aren't really factual?
It's very challenging. I found one of the key things was seeing patients frequently and reinforcing the messages frequently. If a person just has one flare in the ER and then they don't have any follow-up at all until their next flare, during all that time, the uric acid is still building up, but the symptoms are out of sight, out of mind. So it is hard to tell people that, you know, unless you lower the uric acid, this will come back. And people really fear it, but they don't quite believe it. Or they think that out of sight, out of mind. So many of the myths are myths they've heard from their family, myths they've gotten from the internet, myths that they've gotten from physicians who they saw the first time in the ER, who told them all kinds of zany things. And myths also about fear of taking medications that I've found people got from their friends and pharmacists particularly, who certainly, you know, put the fear in them. So you've got to tease that out and then try to direct it. And then sometimes people will forget and just remember the very first thing they ever heard about the disease. It's kind of interesting.
Yeah, I mean, there are a ton of misconceptions out there. One of them really is the picture that most people have in their mind of somebody with gout who's either an overindulger in alcoholic beverages or eating too much food, so some association with obesity. You know, the science over the last 10 to 15 years has really shown us that gout is predominantly a genetic disease, that it's associated with other external things such as obesity can enhance this genetic predilection for getting the disease, but it's something that runs in families. It's not something that earmarks this person as having had bad lifestyle choices throughout their life. I think that's a big issue that we need to overcome, is the shame of having gout. It's a disease like any other chronic disease, diabetes, hypertension, kidney disease. It needs to be treated seriously like those other diseases as well, and not to feel like you're paying the price for some bad choices in behind you. We've had the whole spectrum of spokespeople for the Gout Education Society, including professional athletes that were in remarkable shape and still are coming down with this disease. So I think that dispelling those concepts is something that we should all work on, just to make it less of a burden for the patients. This is a painful disorder, but as you mentioned earlier, Brian, convincing somebody to take medications for a lifetime for something that early on, at least, is just an intermittent disease. It's not until after a decade or so of symptoms that symptoms may become an everyday phenomenon and worsen from there. How do you address that? with your
Yeah,
patients?
I think it's not so much a myth on this one, it's a misconception, and it's not only by patients, it's shared by apparently a number of clinicians as well. And, I address this by really first and foremost saying, this gout flare certainly got your attention. I mean, you couldn't walk, you couldn't use your hand, you couldn't function, but that's just a symptom. And I use a bunch of metaphors in the clinic. And one is to say, if you have a brain tumor and you have a headache, I mean, the headache is bad and the headache needs to be addressed, but we can make the headache get better. But if we don't fix the brain tumor, you're toast. And this is really not good. And the idea that the flare is the disease is a major hangup for both clinicians treating this ineffectively or not at all, and patients who don't understand because they haven't really been educated about this. The flare is done, you feel fine, and so you're done. But you're not, because the uric acid is building up in your body, in and around your joints. And the metaphor I use for that is to explain to people it's like putting too much sugar in their iced tea. You put some in and you stir it up and it's fine, tastes good. Put a little bit more and tastes better. Put a little more in and suddenly it's settling out in the bottom of the glass. And fairly graphically, I can either explain to them or even show them pictures that if we were to cut in to a gouty toe and open it up and look inside of it, it's going to look like that bottom of the iced tea glass, but it's not sugar and it's uric acid. And unless we get rid of that, the disease is never going to go away. So I start basically with those, those stories books, and explain what this is. And then say that, I can use the C word here, which I can virtually never use for anything else in rheumatology and very few things in medicine, that I can cure this disease. And I can cure it by getting rid of the uric acid at the bottom of their iced tea glass. And we do that with, keeping the urate level low and forever, because then instead of the uric acid going from the blood into the joint, it's going to go from the joint back into the blood and ultimately get rid of it. The deposits are gone and their disease is gone. And with that backdrop, say, but if you stop the treatment, if you stop the treatment that's keeping your urate level low, it's going to go back up high and it's going to start to settle in your foot again, just like more sugar in the iced tea glass that's what's going to happen. And, I think over the years that's really been effective for, really the majority of my patients. And looking at the numbers that you and Rick have cited, which I think are very true from the literature, that's really not been my experience in clinic. Once I really spent the amount of time talking to people about what this disease is, the compliance over a long-term experience with this, decades, has actually been far better. So I think education is the key here.
Yeah, I think I would agree with you. And I think Joan would, because she has a very, very high success rate. Rick, while we're on the topic of misconceptions and myths, and with Brian talking about sugar so much, what do you think the role of diet is, or other approaches to the hyperuricemia that might be helpful, but either get bad press or no press?
So I kind of think there are four main drivers of uric acid, okay? And one is diet. And so we can talk about that just for a minute. Alcohol really does increase uric acid levels, beer in particular. And people who drink heavily are at increased risk of getting gout. Sugar also generates uric acid and high fructose corn syrup. It's the fructose component. And people who eat a lot of sugar do raise their uric acid levels, and it can precipitate gout as well. Very sweet fruits have been known for years to potentially trigger a gout attack. Purine foods, which purines are kind of breakdown products of DNA and nitrogen kind of compounds. They're present in rich meats like gravies and organ meats like liver, sardines, the brewer's yeast and beer, they all can generate uric acid too. And so you can raise your uric acid from sugar, purines, and alcohol. And it is real. So diet is important, but it isn't the only thing. And the second of the four is genetics. And genetics are really important. You know, if you come from a line where gout was present in your parents, and you know, it's going to be, you're going to be increased risk for that too. A third is situations like obesity does raise uric acid. And if you can lose weight, you can reduce your uric acid a little bit. And sleep apnea, when your oxygen levels fall because you're not breathing adequately, or there's a problem, what we call sleep apnea, that can generate uric acid as well. And anyone who gets gout should look at the question of, do you have sleep apnea? Is your CPAP working well? Can I try to lose weight? Can I watch my diet? Can't do much about my genes. And the fourth problem is kidney disease, because we mentioned that the kidneys get rid of uric acid. And a lot of people with gout have kidney disease. So these four things you should look at. What's your diet? Do you have sleep apnea or an obesity? Can you work on that? What are my genetics? And, do I have kidney disease? And based on those four things, you can kind of get an idea of, what might be driving your gout. Mm-hmm. And you should, although almost everyone with gout is going to probably need a medication, because, if you have kidney disease, diet is not going to lower the uric acid very well, because the problem isn't just making or eating the uric acid. The problem is getting rid of it. And so, there are all these things, but I do believe that, you should address these things as part of your plan. So if you're eating a lot of sugar and you're eating a lot of purines, try to cut that down. It's going to be hard to cut it out, but try to cut it down. If you're drinking soft drinks, that's a big cause of gout. Just try to cut it out. Drink more water. There's so much evidence that people with gout are dehydrated, and obesity is associated with dehydration. Drink more water. That can lower uric acid. So diet.
So these highly restrictive diets that have been the fad for decades past, of eliminating everything with a purine in it, probably don't do much except convince the patients they're not going to go back to see you as a doctor, because you're telling them
terrible diets.
So
I agree.
So everything in moderation.
If you go on a no purine diet, the food's going to taste terrible, and you're going to lower your uric acid just a little bit, maybe a milligram. It's not going to be, probably not going to be enough. Maybe for some people it will be, but it's a miserable diet.
So cut out all sweetened carbonated beverages, but everything else in moderation is a reasonable approach for that.
Good rule.
Let's move on to treatment for a minute here. And we usually break the treatment of gout into two categories: the medications that we use to treat the acute pain and suffering of the gout flare, versus the really big ticket item, which is lowering uric acid over the long run being a lifetime, in order to prevent the disease from progressing. And if you get it low enough, you can reverse problems that have come up. Joan, maybe you could start off by just giving us an overview of the medications that are used to treat the acute flares of gout.
The interesting thing about gout being so painful is when people come with an acute flare, all they want is some sort of comfort from this pain. It's really not a teachable moment, I have found. This isn't a time to discuss, renal insufficiency or the uric acid pathways. They just need to be relieved of this pain and see you as somebody who understands that the disease is not humorous and is extremely painful. So depending where, if they've ever had a flare before or where they're at in this flare, that's kind of where you make a decision about what kind of medication to use. We can use colchicine, which is an oral medication used for many, many years. We could use non-steroidal anti-inflammatories like Motrin and Celebrex. We can use corticosteroids. They work fast and quickly. They have their side effects, can't use them in everyone. We can use certain specialty drugs that, you know, we have on hand for people who may have had all of these medications and we're not able to break the flare. We don't use them a lot, but they are there for us. And sometimes I'll use corticosteroids and a shot of, you know, a shot of Toradol for pain in some people. So the approach really depends on if it's the first time, how long they've had it, what they've been doing to date, and you know how advanced the disease is. But it is something that's severe and can be relieved in the office or in the emergency room.
Mhm. Yeah. Do you do anything different, Brian? Do you have any comments on this?
No, I think, you know, Joan certainly hit the categories. And I think what mainly influences the decision of which medication to use is really based on the comorbidities, the other diseases or the other processes going on in a given patient. I mean, there's nothing that's going to get me a phone call from Rick Johnson or one of his kidney colleagues by giving a lot of non-steroidal drugs to somebody who's got fairly significant chronic kidney disease, or getting a phone call from an endocrinologist for somebody who's right on the brink of needing insulin for their diabetes and giving them a whole lot of steroids for a very long time. So I'm really going to look at the other medical issues that go along with the patient's gout and need to be attentive to that. There's an emergency room reflex that, well, if there's pain, let's give narcotics. And narcotics do have some small role in the management, but certainly this is not the major drug to be used in patients who have gout. This is pain from inflammation, and the treatment for pain of inflammation is really anti-inflammatory drugs. So any of the ones that Joan indicated we'll use. I tend not to be a fan too much of oral colchicine for patients, particularly if they've not had it before. I don't find it gives you total relief as much as some of the other options. But once the patient knows what they respond to, that's the medicine that they're going to use again and again and again until the flares actually stop. And I take the moment to emphasize to them that we can stop these flares from happening with actually treating the disease, not just treating the flares.
Right. Well, I think those are the main drugs that we use for sure. I think an important caveat of all this is that it probably doesn't make a difference whether you're using colchicine or the corticosteroids like Medrol or prednisone or the non-steroidals. They all have roughly the same efficacy in treating it. The issue is how soon after the onset of the flare do you start them? And I think that there's good evidence that if you have the pill in your pocket, so we have a pill in a pocket sort of concept going on here, that people with gout should always know, have a supply of whatever of these anti-inflammatory drugs they do with them. They don't have to wait for their doctor's office to open up on Monday morning. They don't have to run to the pharmacy. They have the medication that they need to treat their flare with them. And if they can get that started in the first 6 to 8 hours of the pain, they can head a good part of the pain off at the pass. And I think that's important. So the pill in pocket has become kind of an approach that I think is quite worthwhile. Let's move on
It's
to
critically important, I think, that diagnosis of gout has actually been made correctly to begin with. Because you don't want people without proven gout or really confidently diagnosed gout to be taking this, because you could have an infection in that joint instead that gets a little bit better with the medicine, but then comes back and ultimately damages the joint. So the key to Larry's point about pill in the pocket, which I totally agree with, is the correct diagnosis to begin with.
Absolutely. Why don't you stay here, Brian, and just tell us what the
Where am I going?
A little box.
Yeah, that's right. Why don't you tell us the kind of medications that we use to lower uric acid? What are our choices there?
So there's two kind of bucket approaches. One is to trick the kidney into being more effective at getting rid of the uric acid in our body, because that for most patients is the major issue. Even without significant kidney disease, most patients with elevated urate levels have it because the kidney doesn't efficiently excrete it. Right now, really the only drug that we have available for that specific purpose is a medicine called probenecid, which is very effective, is used, but it's not used very popularly. The second bucket is to decrease the body in making uric acid, and that's the approach that is most commonly used. The two drugs for that are allopurinol and febuxostat. The brand name for that is Uloric. Some of you may have seen that advertised on TV in the past. So it's one of those two buckets of either decreasing the body's ability to make uric acid or increasing the body's ability to get rid of it. And the first bucket, decreasing the synthesis, is what's used. Allopurinol, certainly in the States, is the far and away the most common drug that is used to do this. Although I would say all the studies have shown that to date, and still, despite a lot of education, it's still underutilized in terms of appropriate dosing. And that's a major challenge, because it's not just that you give the drug to a patient, you have to use it in a way that it's effective. And again, thinking about if someone is diagnosed with high blood pressure, hypertension, there are many drugs on the market that'll work, but we don't just give a patient a pill and say, this is a great drug for hypertension, take it and I'll see you in 6 months. We're going to say, we want you to follow your blood pressure, know what your blood pressure is, and we want to double check that to make sure that you're correctly treating the hypertension. And the same thing with allopurinol or febuxostat. We're going to prescribe that. We're going to start for various reasons at a very low dose, and then just slowly increase up the dose. And the correct dose of either of those medicines, or if you're using probenecid, the correct dose is the dose that gets you to the urate level in the blood that we want it to be at. And that's at least lowering it to a measurement of 6 milligrams per deciliter, or 6 is a magic number, because that's below the level of which urate is going to settle out in the joints. Just as, we talked about before with the sugar in the bottom of the iced tea glass, it's the urate in the blood needs to be below 6.
Agree fully. Just Rick, maybe you can come in for a second. One of the big problems with managing gout chronically is underdosing of allopurinol, and a lot of this has to do with the concomitant kidney disease that a lot of people have. There's a belief system out there floating around in the ether that you can't use regular doses of allopurinol in people with kidney disease. Do you combat that in your own practice, or do you see that?
Yeah, I mean, we always do start allopurinol at a low dose.
Right.
So
For
we'll start
everybody.
it at 50 milligrams or 100 milligrams, which is a very low dose.
Mhm.
And I like to then titer it up every 2 weeks to 3 weeks.
Mhm.
And so I'll go from 50 to 100 to 200 to 300. 300 is usually your standard dose. But even there, it may not work. There are a lot of rheumatologists that will continue to increase the allopurinol if it gets to 300. And it seems to be relatively safe to do so. My preference is that if 300 of allopurinol doesn't work, I switch to febuxostat because it's that drug is not modified in renal failure. It's fairly potent, and I find sometimes that is a good way to go. So that's what I do, but I know others will titer the allopurinol higher. I think you do that.
I do that. And the truth is that the treat to target is the same for
Right.
people with kidney disease as it is for people without kidney disease or heart
Right.
disease without. So
Well, people, I should make another comment. You know, people who have very severe gout, and even with these drugs, if you can't control the uric acid to under 6, there is another treatment which I suspect you were going to bring up, but
yes,
there's a drug treatment called pegloticase, which is an enzyme that metabolizes or it breaks down the uric acid. And it can take the uric acid levels down very well. So if you cannot control the gout with these other drugs, then this becomes a good candidate treatment to really control the gout. And the other thing to mention is in kidney disease, once you have pretty bad kidney disease, we tend not to want to give drugs that make you urinate the uric acid, because there's some evidence that when the kidney isn't working well, there's not a lot. It's easier to get problems from like uric acid stones and so forth. And so if you give a drug that makes you excrete the uric acid and your uric acid levels go very high in the urine, that's not good for the kidney. So in general. So so we tend to use these drugs like allopurinol, febuxostat, and then if they fail, we might go to pegloticase.
yeah. You could add a uricosuric once they're on a drug like allopurinol or febuxostat. Brian, just quickly, tell us which patients you consider the use of pegloticase, the newer, probably underutilized, good drug for advanced gout.
Right. It's actually a stupendous drug for those patients who respond to it, because it really does help dissolve the uric acid deposits far more rapidly than any of the oral drugs that we have, in part because it takes, as Rick said, it'll take your uric acid level essentially down to 0. And it is not an easy drug to use from the patient side, because it's an intravenous infusion that you have to come into the office every 2 weeks and get an infusion, which lasts a few hours. But it'll get those deposits. If you're one of those patients that has these enormous tophi on your elbows or knees or fingers, it will dissolve those over months. So it's very effective if you respond to it. So I will use it in patients who have enormous deposits and have really decreased functioning of their joints, and their activities of daily life are dramatically affected because of the deposits. Some patients who we need to stop the flares more rapidly over time, because they can't, they're a truck driver, they drive distances, they can't stand having flares. So we need to stop those flares more rapidly by getting rid of the deposits. So those are patients that I will consider using the drug and have that long discussion with patients why this may be something for every 2 weeks, inconvenient for maybe 4, 6, maybe 8 months. But when that's done, we can go back to traditional, because you're going to need to use traditional urate lowering drugs after the pegloticase. But then we can go back to oral therapy and keep those attacks from happening again. So it really is a very select group of patients who I'm going to use this drug for, but with optimism that it's going to stop the flares from happening and relieve those massive deposits in places far more rapidly than I can do with oral therapy.
Yeah, you can do in months what would take many years to do with more traditional approaches.
Yeah, it's really, for those patients who respond, it really is incredibly effective drug.
Okay, let's go on to another discussion point here. The patient has gout, but hasn't been diagnosed and is going to go in to see their healthcare worker. Joan, what kind of questions, what does the patient need to take in with them when they go in to see the doctor?
They're coming in with suspect gout?
Well, they've had an attack of something that they thought their foot had been broken, and then it got better after 7 to 10 days. And their father told them that he had that, and he continues to have it, and it's gout. So he suspects it.
Yeah, and when it's responded to an anti-inflammatory and ended relatively quickly, that's always another reassuring measure that this is gout. And not infection or, other disorders. So if we feel that this is an established diagnosis, or there's a high confidence level that this is gout, this is your teachable moment, because the memory of the pain is still fresh. And I try to use this as the launch into basic teaching about what urate lowering does for them, how it works. I use different analogies, but then Dr. Mandell used, but it's basically the same. I use the salt one. And people will get that. And usually what I find is that if they have a family history of it, or if it was an excruciating experience, or if it was they've had several of it, they're ready for treatment. They're ready for treatment. And but many people aren't. It's just they think it's one and done, and they want to try diet. And I think what I try to do is say, we're still here for you. Here's why I think it won't get you to goal. And there is a goal. There's an established target of having a uric acid of less than 6. But if you really want to try your own little things, like, we're still there for you. And this is when I also make sure that they have some rescue remedies, something like a Medrol dose pack on hand. You never want them to feel it's a punishment for not doing it your way.
David, maybe I can ask you, how did you go in to get your gout diagnosed? And what kind of help did you get from or education did you get from your healthcare provider?
Well, I went to my primary care physician after a significant amount of time. I should have gone a lot sooner, but when I finally went, I went over there with nothing in my hands as far as lab results. I needed the lab results to be ordered from him first. And I told him what I thought it was. I don't think he liked that. I think he wanted to come up with it himself, but he said, let's get some lab work done and make sure the uric acid level is where it's not supposed to be at. He hadn't given me the allopurinol yet, of course, until he got the results. But as soon as, I think I was looking at it right now, and I think it just said above 10 as my level. And he immediately ordered it. He didn't give me any other advice as far as diet, anything else. Like, he just basically said, let's try the allopurinol, and I'm going to give you some meloxicam whenever you have a flare up for pain, which absolutely did nothing. So I was just basically going off of the allopurinol for a while, and I didn't see any significant change until later on.
So you mentioned the lab testing. Brian, we have a target of less than 6 because that's puts us down below the saturation level of uric acid in blood at normal pH. Is that the only target we shoot for? And how often should somebody with gout get their uric acid measured?
Yeah. So I'll back up just one thing from what David said. Something that I've seen very frequently in practice that is a cause for confusion is this number of, what's the urate level that matters. And it really has to be, significantly below 6.8, which is the saturation. But if you look at the laboratory results will say you're normal in some labs up to almost 8. So you can have a normal uric acid level. So you get your doctor checks the uric acid level and it comes back at 7.6. And they say, well, you're normal, you don't have gout or you don't need to have this treated. But that is so false, because it's not the laboratory normal in a population that matters. It's the biologic behavior of this uric acid. So we really do target in someone who we know has gout to keep that level significantly below 6. Now, what we've learned is that the lower the blood urate level, the faster those deposits are going to dissolve. So when someone who has lumps and bumps that we can feel, or has significant number of flares per year, 6 is not low enough for me because I really want to get them out of this flare phase as fast as possible. So I'm going to target those patients to be significantly below 5, maybe to 4. And those, as we talked about before, if they're, massive deposits or what is called tophi, I may use pegloticase to get them to a level down of 0 for a while. So it really depends on the patient, how low that I want to go. And I want to make sure that that level is there. And I'm going, as I'm titrating, I'm going to check, as Rick said, probably every 2 to 3 weeks as I adjust the dose. And then with somebody who's on it, I want to make sure that it gets checked again in a month or 2 months, in part because I want to reinforce to the patient that they're doing the right thing and the drug is doing the right thing. And then once you're on a stable dose, I think every 6 months to a year is sufficient unless there's some change in the clinical condition. There's more medications that have been added. If they've had a major weight gain or they've major weight loss or medicines, then I'm going to check it more frequently.
So the target, we say treat to target rather than treat to less than 6, just because the target will vary on how rapidly you want the uric acid to come down and how extensive the disease is. So that conversation, the patient should understand what their target should be. They should know what their last serum uric acid level is, pretty much like diabetics always know what their morning sugar was, or their hemoglobin A1C, or people with hypertension know what their blood pressure is running. People with gout need to know what their uric acid level is. And when they get on a stable dose of urate lowering therapy, they should still have it monitored every 6 to 12 months, just because other things change in their life. New medicines get taken that might affect it. They may gain or lose weight and have some effect on that. So I think all of those are important aspects to keep track of when for the patients themselves. There's a good discussion on our website about treating to target, and remember the gouteducation.org website contains this. And if you have a care provider that seems uninterested in the disease and you're wanting it treated better than it is but can't find it, there's also a section on our website called the Gout Specialist Network, and we've identified about 900 physicians across the country that like treating gout, that they know the right things to do according to the guidelines of the American College of Rheumatology, as well as other international organizations, and they will do the right things. So let me just.
Or you could just learn to train your doctor into doing the right thing.
Well, that happens too, and I've had a number of physicians call in to say that our website has done exactly that. That patients came armed with information, which sounds dangerous, I guess, if you're a physician.
In Florida.
But let me just reiterate what we've done here over the past 55 minutes. We've talked about gout as being a chronic disease, not just something that's hallmarked by flares, but untreated, undertreated, it will progress into a crippling disease that's very serious. Therapy for it, comes in 2 forms. Treating the painful part of it is brief, covering a week or 2. The more important is recognizing that gout is a disease of elevated uric acid. That's the cause of the problems. And the cure, as Brian said, is to lower the uric acid. And you need to be on a different set of medications for that. And you're really not making any progress with your disease until you get the uric acid at least below 6. And if you want quicker resolution of the problems and get to a state where you don't have flares, maybe the target will be even less than that. Lifestyle changes, as Rick has said, are important. Getting on a sensible diet. I think a lot of gout experts recommend something on the order of a Mediterranean diet or the DASH diet for hypertensives. people, not terribly restrictive. You don't have to eliminate everything that tastes good in your life, but everything in moderation, I think, is the right approach. Again, we talked about treating to target, know what the target is. It needs to be less than 6 if you're going to make progress, but it might be even lower. And then the fill in the pocket for people with, as far as their flare medications, they need to be able to get to that quickly, because treating the flare early on is very important. And then treat to target for the uric acid lowering therapy is the model that we would use. I want to thank everybody that tuned in tonight to watch this webinar. I hope you learned something. If you have questions or thoughts about what was said by any of us, don't hesitate to contact us through the Gout Education Society's website. You can leave questions and ask one of us to answer them, and we'll get you a comment back. So visit us at gouteducation.org. I also especially would like to thank our expert panel that was here today. I thank David for sharing his own history of gout. That I think that was very helpful. Joan, Brian, and Rick, he did an outstanding job as expected. True specialist, internationally recognized, and we appreciate it. Thank you. Hope everybody has a great evening.
Thank you.
Look for us on the website. Bye-bye.
Bye.
Thank you.